Hi, everyone. This lecture will be on blood vessels and circulation, part of the cardiovascular system. That would be chapter 20 in our anatomy and physiology book. So let's get started. In this slide, we're showing the different structures of veins on the left and arteries on the right. Let's start before we get going too far in this with something that all vessels have. They all have an innermost epithelial layer called an endothelium, and this is even true in the heart. Outside of that endothelium, you have what's called a basement membrane. All epithelia have a basal lamina. That's what basement membrane means. Basal lamina and basal membrane are the same thing, just different languages. But if you look here in the large artery where we have most of the structures you need to know, you can see that dark purple layer here and here and here, so forth. They all have that endothelial layer with the basement membrane. That's called the tunica interna. Then we have a layer of smooth muscle, which can be sensitive to certain signals and hormones. Particularly nitric oxide, it's a signal. That's called the tunica media. And then you have in the large artery, like an aorta or a major vessel, you have a what's called a tunica externa, which is elastic connective tissue. As the blood is squeezed into a large artery, the artery actually relaxes and then squeezes. It's going to sustain pressure in the arteries. In fact, we call the arteries a pressure reservoir for that reason. And we have smooth muscle going all the way down to the arterial and maybe even a slightly smaller to meta-arterial. And what happens is you're sustaining that pressure in order to keep the blood moving downstream. All right. So we squeeze blood in, the vessels relax for a split second, and then they squeeze after the heart begins relaxing in order to sustain that circulation. On the venous side, you have a lot less muscle. You can get a little bit in there, especially at the very, very end. But one of the major features that are in veins, primarily the medium-sized veins, although you can get them in smaller as well, are these valves. That's because the pressure on this side is so low that you need skeletal muscle contraction in order to generate enough pressure for the blood to return. But you don't want to lose it to gravity, so you have these valves that ensure unidirectional flow. Here's a picture of a relatively large artery. We have the lumenal space and the endothelium, tunica externa. You might even see a little basement membrane there. Tunica media, that's smooth muscle. Tunica externa here on the outside. Over here on the right, that's actually looks like a vein or something. Maybe another blood vessel. They're hard to tell, but that looks much more like a vein to me. But this is definitely an artery right here. And just another picture of an artery here. Again, just the major interna, media, and externa. Okay. Intima is just another word for interna. Here you can see in the arteries different sizes. All right. They talk about elastic and muscular and arterial. Okay, this is just smaller and smaller. These would be the very, very large arteries that have lots of tunica externa, elastic. This one's got a fair amount of muscle, so kind of a medium-sized artery. And then you see some muscle here. When we talk about arterioles and meta-arterioles, these muscles do a lot in terms of regulating whether blood is distributed to a given tissue or restricted. When it comes to capillaries are basically two layers. You have an endothelial layer, and then just outside the endothelium, you have a basement membrane. So you can see three different kinds of capillaries here. We have what are called continuous capillaries. These are by far the most common types of capillaries that we see. We have very specialized capillaries called fenestrated capillaries, which we find in the kidney, in the glomerulus of the kidney. And then we have sinusoidal, which we find in organs like in endocrine glands and bone and some other places where extra exchange is needed. The fenestrated is actually a true filter. It's actually allowing fluid out, but retaining formed elements and large proteins and molecules inside the blood plasma. So these are the smallest ones. They're also the most easily damaged and most easily repaired as well. We talked about vasospasm the other day for maintaining hemostasis. Well, the vasospasm is always at play in the meta-arterioles and the arterioles upstream of injured capillaries. But the role of these capillaries is for fluid to move out and in. So we force more fluid out than in. Okay, so we have hydrostatic pressure pushing out, we have osmotic pressure pulling in, and that's true with all of these different types of capillaries. To the tune that we get a little more out than in, and it has to be returned through the lymphatic system. So we're exchanging oxygen, nutrients, also exchanging wastes as well, things coming out of the tissues back into the blood plasma. That's part of the reason why these cells are so very, very thin, because diffusion is distance limited. And most capillaries are using some kind of simple diffusion, especially for gases. All right. There is some fluid exchange as well, and some things can get transported that way, but most of what we're dealing with here is simple diffusion. I explained a lot of this in the previous slide. Again, the difference here, we have continuous, we have fenestrated, and we have what are called sinusoidal. Main thing is to understand why they're different and where you typically find them. You find these in the glomerulus of the kidney, a pretty singular place. Find these in organs, find it in bone marrow, liver, spleen, that sort of thing. When we say perfusion, what we are describing is how much blood is being circulated into a tissue, right? If you ever hear in lungs when we talk about VQ ratio, V is ventilation and Q is perfusion. A lot of these capillary beds, like this one we see here, can be turned literally on and off depending on metabolic need. All right. If metabolic need is low, these precapillary sphincters in the meta-arterioles and in the arterioles to a certain degree will clamp down a little bit. You'll still get a little bit of blood flow, but not very much. All right, because you don't need it. It's low metabolic need. But in periods of high metabolic need, these will dilate and all these capillaries will become flush with blood. You can even see that on the surface of the skin and so forth, erythema. All right. That's where these things open up and then allow more blood flow. So it's a capillary bed. Capillary beds never truly shut down. You do have usually what we call an AV shunt. So if some of these guys sort of shut down, you still have blood moving unidirectionally to the venous system. In cases of tissue where it would be absolutely catastrophic for complete, for loss of blood perfusion, we occasionally will have an anatomical structure known as an anastomosis, where we have two blood vessels coming from different directions that will then unite in order to perfuse a given tissue. Like, for instance, we have carotid arteries and other ones here, other structures. Most of the time we see these anastomoses in veins. All right. We do see some in the arteries. All right. Again, they provide alternate sources of blood, a little bit of redundancy, if you will. Minimizing the risk of ischemia to tissues that really cannot tolerate ischemia very well. So here we have a nice summary of the features of arteries and veins. It's all about the muscle because arteries are what we call a pressure reservoir. The heart injects blood into the arteries, and then the arteries will squeeze in order to sustain the pressure, keep the blood moving past the arteries into the tissue. Blood isn't doing anybody any good sitting around in an artery, so the arteries are a pressure reservoir designed to keep that blood moving out into the tissues. Veins, on the other hand, have larger lumens and they're less stretchy. They can even become distended. That's what we talk about varicosities, varicose veins, and so forth. They need valves because their pressure is so low. This larger diameter, that means that veins are actually what we call a fluid reservoir, and they have anywhere from 55 to 60% of all the blood in the body is found in the veins. So at rest, what we see here again, most of our blood is in our veins, comparatively little in the arteries, a little bit in the heart, more in the heart than the arteries. That's that kind of interesting, right? Little capillaries and so forth. Most of us are familiar with blood pressure, but many of us don't exactly know what blood pressure is all about. What blood pressure is telling us is what the peak pressure is when the heart is in what's called systole and ejecting blood into the heart, and then what we call diastole when the heart is at relaxation. And so what happens is as the blood goes, it rises to 120, drops to 80, 120, 80. We call that a pulse pressure. Right? Systolic, that is when we are getting active ejection into the arterial circuit. All right. Diastolic is when we are in full relaxation in the heart and the pressure is dropping in the arteries because the fluid is leaving. Remember that arteries are a pressure reservoir, veins are a fluid reservoir. So as the arteries squeeze during diastole, that blood's leaving, which means pressure is dropping. I mentioned in an earlier slide that arteries do tend to get less elastic over time, which means that we begin to see an elevation in the systolic pressure because the arteries just don't expand as much as they used to. Okay, the arteries actually just get less elastic. And so what we see are higher systolics, occasionally a little bit higher diastolics. All right. If those diastolics gets much higher, then a clinician will probably prescribe an antihypertensive of some kind. If we have hypertension, particularly if it lasts for more than a few days or weeks, we're talking about systolics averaging above 140 and diastolics averaging up above 90, as we mentioned in the previous slide. On the other side, we can have hypotension, and the problem with hypotension is fainting or exercise intolerance, inability to get up and out of a chair without having significant vertigo, that sort of a thing. A resting systolic of under 90, all right? We generally get concerned if it's under 100, all right? So if it's under 100, it's already in kind of a bad place. And any diastolic that's at or below 60. So often we rely on computers and devices in order to measure blood pressure that we often lose track of how blood pressure was originally determined in the first place, which was using a mercury barometer that measures pressure, barometer, all right, along with auscultation using oftentimes stethoscope. You can also do it by palpation as well. What computers do is they look for the up and down register of pressure, and then they'll say, oh well, that's enough up and down that's where the systolic is, and then when it starts to weaken, that's where the diastolic is. What we do is we listen for the first what's called a Korotkov sound. So you're hearing blood squeeze through this tourniquet, and when it's squeezing through that tourniquet of a blood pressure cuff, it makes a turbulence sound that you can pick up with the stethoscope. So you hear the onset of sounds for systolic, and then you hear the sounds they don't completely go away, but you hear them you hear it kind of weaken significantly, and that's your diastolic. So here is a graphical representation. We get that first pulse wave getting through and hear a Korotkov sound. When the sounds diminish, that's our diastolic side. So the onset of Korotkov sounds is systolic. One more little point here. It's not well illustrated in this figure, but we're going to go ahead and kind of talk about it. 2/3 of the way down from systolic to diastolic, right about where my pointer is, averaging about 2/3 of the way down, is what we call mean arterial pressure, MAP. And that is the average pressure over time. Average pressure over time. And since we're in diastole 2/3 of the time, the mean arterial pressure will typically calculate about 2/3 of the overall pulse pressure between systolic and diastolic. So if we put a little line in here, it'd be right about here, right around 92 or 93. And then we would see it gradually get closer and closer to the diastolic as the difference gets smaller and smaller between that when we're doing auscultation. Given that perfusion is so important and needs to be nuanced, if you will, we can't just send all the blood to every tissue in the body all the time. That would lead to a massive drop in blood pressure. And the word is parsimonious. That is to say, how do we make do with less volume? We preferentially distribute blood to areas where metabolic need is most of the time. Have you ever heard the old adage, hey, don't go swimming right after you've had a meal? That's because when you eat a meal, your blood is shifting away from your skeletal muscle and towards your digestive tract in order to accelerate and maximize absorption. That being said, if you try to do massive muscle exertion, you'll have this sort of conflict of interest. The signals will be saying, send blood to the GI tract, and your muscles are like, send blood to us because we're working hard, and then you're often vulnerable to cramps because of that, because now you're basically fighting a blood tug of war. So there are lots of ways that we can control blood pressure. All right. Certainly sympathetic and to a certain degree parasympathetic. Sympathetic will increase blood pressure because when we are in fight or flight, what we need is more blood delivery. We can also vary blood pressure through injection of blood into the container of the arteries. So if we accelerate the heart for any reason, whether it's a combination of metabolic need or sympathetic activation, it will trigger increased cardiac output. You can also control volume over time. This is kind of a slow mechanism. These other two ones are actually quite fast, second to second kind of thing. But this one here, number 3, is actually hours and days. Like if you go to Denver or a high altitude city, they say drink a lot of fluid because it's going to take you 2 or 3 days to kind of catch up. And that's what they're talking about. Antidiuretic hormone, another hormone called aldosterone, part of the renin angiotensin aldosterone pathway. Both of these, what they do is they affect the kidney and cause the kidney to be even more aggressive in resorbing material when possible. You do have what's called a vagus or a baroreceptor stretch receptor in blood vessels. This is, if you've ever seen, like I like to say, Chuck Norris, he gets his legs wrapped around somebody's neck. Yes, he is depriving the cerebral vasculature of blood doing this, but he's also activating baroreceptors, which happen to be found in that area, which cause a drop in cardiac activity. And so not only are you depriving the cerebral vasculature of blood, you're also getting a double whammy out of it by causing blood pressure to drop precipitously. You also do have chemoreceptors. So if you find yourself with low oxygen or high CO2 and or low pH, that's acidity, all right? High CO2 and low pH tend to go hand in hand, but they are separate. Oxygen is the same way. So if you have low oxygen, everything else is fine, you'll start increasing blood pressure. You have low pH and high CO2, same story. So why all the fuss about hemodynamics? If we deprive almost any tissue for more than 30 minutes, and specific tissues like the brain, the heart, the kidney, then you're talking about maybe 4 to 6 minutes under normal circumstances. You're going to start to see overt tissue damage and loss of function. All right. That's why there's a lot of fuss here. All right. That and the blood, blood tissue perfusion is a dynamic system that affects the entire body, even if you're just trying to target one tissue. All right. Perfusion, if you will. All right. Because we need O2. We need to remove CO2. We certainly need to deliver nutrients and certainly remove nitrogenous waste and things along those lines. If we have anemia or anemia, that means that we have lost the ability to carry oxygen, and there are several ways you can have that happen. You can have low oxygen concentrations, like say at high altitude. You can have poor cardiovascular performance or blood loss, or you can have overt poisoning of the cells with something like cyanide, and so forth. There's 3 or 4 different types of anemia out there. All right. If flow is increased, we call that term hyperemia. For instance, if you were to flick your arm with your middle finger and cause a little welt there, you'll see redness there. Hyperemia is one of the cardinal signs of inflammation. Hyperemia can also be observed in people that have elevated body temperatures, or if they've been occluding blood flow on, like say, on the skin for more than say 20 or 30 seconds, and you remove your hand, you'll see a little bit of reflex hyperemia there in order to sort of recoup the buildup of wastes and gases. So you see a little bit of localized hyperemia following a mild ischemia. Right. When flow is decreased, we call that ischemia, or if there's plenty of flow but not enough oxygen, we call that hypoxia. If we have no oxygen, we have anoxia, and that leads to necrosis, an uncontrolled type of cell death that's pro-inflammatory. Our body does have, in the adult form, has 2 main circuits. You have the pulmonary circuit coming off of the right side of the heart through the lungs and then back to the left side, and then the systemic circuit coming out of the left side, the aorta, going to the cerebral vasculature or down into the lower part of the body, returning as deoxygenated blood. Now, like I said, we have the pulmonary circulation going to the lungs. We have the systemic circulation going to the distal areas of the body, or the main abdominal area. The third circuit that we have only temporarily is called a fetal circulation. That's because you're not going to be able to exchange any gas in the lungs. And so there's no point in sending a lot of blood out to the lungs for gas exchange that doesn't exist. So instead we have this sort of hybrid circuit whereby we are sending blood out into the placenta and then returning it back. And so the placenta is not nearly as oxygenated as the lungs. So again, it's kind of a hybrid system in the fetal circulation. That's what gives rise to our belly button, by the way. Okay, the residual artery and vein goes through the umbilicus to the placenta. And here we have an illustration of how veins return blood to the heart. Veins are a low pressure, high volume system. They are a volume reservoir. So we have these valves in here. So anytime we have a skeletal muscle contraction, like say in our legs when we get up and walk and so forth, we're pushing that blood to the heart, and that blood gets trapped, can't flow backwards from that valve. I can even show you on my hands a way to identify where the valves are in the veins in my hands. I have a little trick to do that. So we have valves to prevent reverse flow. We certainly have contraction of skeletal muscle. And we do have diaphragmatic and accessory muscle contraction, both of which are skeletal muscle as well. This just happens to be in the pulmonary cavity. And so that chest movement also contributes to squeezing blood back to the heart. Here is our illustration of venous circulation. So we have the venous duct, which is right in here. It's a little bit tricky to see. All right. We have the oval opening in the heart. Remember how I mentioned it was it's a hybrid system, and then we have the arterial duct, which again sends the blood down out through the umbilical arteries into the placenta for gas exchange. Then we have the umbilical vein coming back, which then leads to the venous duct, which takes it back to the heart. That crosstalk that I mentioned, that hybrid system, if you will, that I mentioned in fetal circulation, one of the primary structures is what we call the foramen ovale between the two atria. Under normal developmental circumstances, right at the time of birth, you get a massive dilation of the pulmonary arteries, and that causes a pressure change that then causes a flap of material to close over the foramen ovale, literally at the moment of birth. But about 2,000 babies a year, all right, are born with atrial septal defects, which means that their foramen ovale is not closed. They start to get shunting of blood from left to right, which leads to inappropriate mixing, inappropriate pressures, inappropriate perfusion. And so that often requires a neonatal or pediatric open heart surgery in order to correct that. And here we have a set of practice structures for you. I'm not going to name them. I'm going to let you guys have at it. Notice we have a capillary circuit here. All right. Can you name the major structures that you can find in this picture? And what kind of capillaries are these, by the way? All right. What's this gray stuff around the capillaries? What are those cells called inside there? What's this kind of funky looking structure? All right. So work on that a little bit. Let me know if you have any questions. And a little bit of dad humor. Certainly thinking about health insurance premiums is enough to raise anyone's blood pressure and could theoretically cause a misdiagnosis, if you will. And here we have, when it comes to identification of arteries, like bones, we have very similar looking things and so forth. The key is to work your way around the system, major arteries, all right, major systemic arteries. Key things that you need to know in order for identification and or characterization. First of all, the name of the artery, and often the name of the artery coincides with where it's located, all right? Where it's located in the body, all right? It's like, for instance, you have the pulmonary artery, for instance, you gotta know that's lung, right? Or the hepatic artery, it's going to the liver, all right? Should be able to spot these on a chart or even better in a model. And what organs are supplied if it's more than one, for sure. Like, for instance, the hepatic artery is going to be obviously the liver. All right. There are some that don't name the organs that they're serving, and you're going to want to be able to indicate. Like, for instance, the carotid arteries. What are those serving? Those sorts of things. Okay. And so we do have a laundry list of these things, but have faith. Okay. They are relatively located. Like, for instance, you have digital arteries in the fingers. Okay. Gonadal arteries serving either the ovaries or the testes. You have a femoral artery. Now, the fun one here that's on the back of the, kind of towards the back of the knee, the popliteal. The brachial artery, that's the one we normally do blood pressures on. The ascending aorta is the one coming out of the left ventricle, all right? And then that begins to branch, and we have some of the more complicated names are actually just right up in this area, okay? Axillary artery that goes underneath the armpit. So a lot of these names you already know. It's just a matter of just linking it to the region, organ system, and so forth. The renal artery, which sees almost 20% of the cardiac output, going to the kidneys. Radial follows the radius. Ulnar follows the the ulna bone. And so if you know your bones, a lot of these things you're going to know just by default. So make sure you get these aortal structures around because they're kind of easy to point to in the models. Big arteries. Some of these arteries are harder to spot, but you should have at least, you should feel good about 3/4 or 90% of these arteries, I think. So what do we got going on here? Well, use your landmarks. Okay, looks like it's going into an atria over here. This looks kind of like the right side. All right, that's got to be the superior vena cava going on here, which means that this coming out of the right side has to be the pulmonary, the common pulmonary artery. Going to the left and going to the right lungs. All right. This is the aorta coming out of here. That's coming out of the left side, and you begin to see some of these branches coming off of that as well. This guy right here, that's the start of your pulmonary circulation. And although this picture has a whole bunch of different arteries, we're looking at 1, 2, 3, 4, 5, 6, 7. All right. So there's 7 on this picture. Vertebral is a little tricky to find. It actually runs right up inside the spinal cord. It's called the vertebral artery coming off of this right subclavian artery right here. You have your carotids, which you can find more easily on yourself than you can find on these structures because, again, they look a little bit similar. Just have some faith. So here's our right subclavian. Our left is not shown here very well. All right. The one that kind of gets people sometimes is this brachiocephalic. It's just this little segment here. In a human body, it's barely 2 or maybe 3 inches. It's super short. Okay. But what happens here is that you have some structures going on. There's some blood pressure monitoring structures in here. This is also the site of sometimes occlusions where you get like in the coronary arteries, because there's a lot of turbulence going on here. This is where you get plaques and so forth. We do have some specific arteries that we want to know in and around the brain. First of all, you have an anastomosis here coming off of the internal carotids. It's called the circle of Willis. And you have these cerebral arteries. You've got a couple of them. You got a middle, an anterior, and a posterior, all coming off the circle of Willis. You have this basilar artery, which is running basically from about the pituitary gland, which is kind of shown right here, down towards the brainstem. It's called the basilar artery, along with the vertebral artery coming along here as well. Again, a laundry list here, but what we have is actually an abbreviated list. Okay. So we have the brachiocephalic, which is a little tricky to see in here. It's just right there, so very, very short. It's coming off of the ascending aorta. It's just before you have your carotid branching off of the subclavian. So so the brachiocephalic splits into the carotid and the subclavian, particularly well visualized on the right side. Intercostal, okay, those are going to be in between the ribs. All right, axillaries, that's going to be underneath the armpit right here. Brachial is going to be sort of on the inside of the arm. This is our blood pressure artery most of the time. Radius and the ulna. So this should not be too difficult, hopefully. And in this photo, we have a list here on the left, but we do have basically 5 major ones. We have the celiac trunk, which services the liver, the stomach, and the spleen primarily. Then you have the superior mesenteric artery, which is going to do like the pancreas and the upper small intestine, the inferior mesenteric artery, which is going to be starting to serve the lower end of the small intestine and the colon. You have the renal artery, which services the kidneys. And lastly, you have what's called a gonadal artery of differing lengths. In biological males, it's a testicular artery running all the way down to the pubic region. And then in females, it is an ovarian artery going just in this region right here of the photo. It's not shown. We have a morphological male in this picture. So you have that celiac trunk that we talked about in the previous slide, where we have the hepatic artery, the common one, got a gastric artery, and the splenic artery. Those are the three major branches coming off of this trunk that's coming off of the abdominal aorta. So here in this picture, we happen to have the celiac trunk, all right, that we just discussed. Then we have the mesenteric arteries, so the upper one, the superior, the lower one, the inferior. Just trace them down in here, okay? It's going to be a little tricky sometimes. What you need to remember is that what organs are they serving? And they're serving the small intestine and or the large intestine. Here's our list for the lower extremities. So we have this common iliac coming off of the abdominal aorta. You have an internal and an external iliac leading to a femoral artery. The popliteal is down here just on the back of the knee. And then you have what's called an anterior and posterior tibial. And if you were to feel one down on the bottom underneath side of the foot, you would have what's called the plantar artery. It's not in this list, so I wouldn't worry about it too much. I'd start with this one here, this list right here. This is sort of the systemic overview of the veins, and we're going to break these out by region as we go. So let's move on to the next slide. You can always refer back to this slide at a later time. Remembering that veins are the blood vessels that convey blood back to the heart. They are the volume reservoir. So we're normally talking about carbaminohemoglobin, a little bit of metabolic waste, urates and that sort of a thing, nitrogenous waste and so forth. So what do you need to know about each vein? Okay, certainly the name of the vein, whether it feels like an arbitrary name or it's a very specific organ or region name. Most often it's going to be the latter, organ or region. Where you can find it in the human body, all right? So generally we're going to use models for this, all right? Organs drained by the vein if the vein itself isn't named after the organ it's draining. Like for instance, there's a renal vein. There's nothing else it serves. We do have some slightly different names. We have the femoral vein. We have the great saphenous vein. We certainly have a popliteal vein. That one's usually a little bit visible. You have a fibular vein. There's a lot more anastomoses here. With that in mind, here is our list that we want to get after. Let's start with the biggest ones. All right, femoral is a good one. Saphenous is a good one. Popliteal, those are really, really good. External iliac's good. And then work on the more deeper veins, if you will. Generally, I'm not going to go through all of these because most of them have similar names to what we have in the arteries. Vena cava obviously being a bit of a departure, but honestly, the veins are generally paired with the arteries for the most part. And here is one big exception to the artery vein mirror image, and that is the hepatic portal vein. It's one of three portal systems in the human body. What it's doing is that you have a capillary bed. The arteries come in here to these GI tract organs, primarily the stomach and the large and small intestines. And then that blood condenses into a common vein that then instead of going back to the heart directly, it goes first to the liver where it forms a second capillary bed in order to potentially detoxify and eliminate compounds that need to be eliminated from the blood. Then it goes to the heart. So we have three of these in the body. And so the biggest one of all, the really big one, is this hepatic portal system. Beyond that, you've got some mesenteric veins. You've got a splenic vein going to the spleen. You've got gastric and pancreatic veins as well. Then those are a little more mirror image to the arteries. The main veins that we want to focus on here are the jugulars. So you have an external jugular and an internal jugular. By and large, when it comes to the venous drainage up here in the anterior part of the body, most of these are going to be regional in nature: temporal, ophthalmic in the eye area, occipital, facial, posterior auricular, kind of underneath the ear here. These things should make sense for you with our focus being on these two, internal and external jugulars. So we have a little mini test here for you. Here's a cadaveric image. You can take a look here. Can you guess which one that is? I'll leave that to you. Take a look around. Get into the charts. Look at the figures. Because at the end of the day, we're going to use models to test you on this sort of anatomical identification. As I mentioned before, a lot of these mirror the arteries. There are a few unusual ones, the hemiazygous on the left, all right, and the azygous right to superior vena cava. But by and large, most of these things have very similar names to the corresponding arteries in these areas. This one running right here, you can see it run right across this area. This is the antecubital area, the elbow. You have a median cubital here. We see that one underlined. But again, should be fairly proximal to the arteries. So get the arteries down and then work on these veins. Lastly, we have the pulmonary circulation. Remember that the arteries are deoxygenated. Do not be fooled by the red here. That's the left side going to the systemic vasculature. The blue here is the pulmonary artery, and the red coming back are the veins. So we have a flip-flop of oxygenation here. Not a lot to say. You do have arteries that go to the different lobes of the lungs. So the right lung generally has 3 lobes. The left lung has 2. That's pretty much where you're going to be. And so there you have it. This is the end of lecture 7. I will be advising you to get into this early before the exam next week. So please do make sure that that you get an early start on this so that you can hit the lab running when we get there. Good luck. Please bring your questions, and I will talk to you soon. Thanks. Bye.